we're looking to see how the baby responds. So the question during the break is, well, what does a non-reactive NST even mean? It means that the baby is not getting enough oxygen. And so I'm gonna, again, look at other things to see how the baby responds, because we need reserve for the baby to tolerate labor. So one of the things that can be done is a contraction stress test. With contraction stress test, it is an outpatient procedure. You have to get informed consent. The patient is often, we do all of our admission routine, things that we do for admission for labor and delivery. So we start an IV, we get admission labs, because the problem is this can cause fetal distress. It can cause her to go into labor. She might need a stat C-section, things like that. It doesn't happen very often, but again, there is risk associated with this test. It's usually done like within a short time frame. So, I would tell the patient to take off work. Like I wouldn't have a contraction stress test and try to go in at noon to work. I would just take the day off from work. Part of it, again, if you're scheduled to go and have a contraction stress test done, you just don't know what the outcome of it would be. There's nothing that she needs to do the night before to prep for it or anything. Sometimes what will happen is they will still allow the patient to maybe drink fluids and have light foods. But again, if it happens to, like we see bad things with the strip on the baby, then they might just restrict her to clear liquids in case she ends up needing anesthesia. Okay. With contractions, they can be spontaneous, so they may be there already. They can be induced, so we'll do oxytocin. So sometimes you'll hear this called an oxytocin stress test, okay? Or you can do breast self-stimulation. So the patient actually will take her fingers and roll her nipple, and that causes the endogenous release of oxytocin to cause contractions. One of the things that's nice about it, it's natural, so we don't have to give artificial Pitocin through an IV. One of the bad things about it is we have no control over it. I can't tell the brain, okay, stop, that's enough oxytocin. It just keeps on, there's no way to stop it. If I'm giving it to you artificial and an IV, I can turn that off because the half-life of PIT is nothing. So immediately it stops going to the body and you'll stop having contractions because I turned the Pitocin off. So there's ways to interpret it, and this is super confusing. Negative, positive, and equivocal, okay? So I'm gonna show you, in this land of healthcare, negative is actually a good thing. So you want a negative CST. A positive CST is a bad thing. And so this is a better picture of late B cells. So I showed you about how I got late B cells on the monitor. I'm gonna see if I did any better the next go around. So here's the peak of the contraction, and notice the deceleration occurs after the acme, or the highest point of the contraction. And so what happens is, I have this contraction which restricts blood flow to the baby, and the heart rate goes, oh, I'm just a little tired, huh? The contraction's easing off, and the baby's like, I'm not ready yet, I need some more time. Okay, I think I'm ready now. That's a late decel. So your baby doesn't have any reserve here. The other thing, look, I'm gonna kill myself on this thing here. Look between, your variability is absent to minimal, okay? This is a bad strip. This is a patient who we would stop the contractions, we're gonna turn her left side, we're gonna increase IV fluids, we're gonna give her oxygen, and if it doesn't resolve, she's gonna get a stat C-section. So notice up here, this is a negative CST. What makes it negative? The absence of late decelerations. They can have other types of decelerations, but the absence of late decelerations makes it a negative CST. Okay. Now, if we look at this up here, this particular strip specifically is also a reactive NST. Okay? So I want to show you a non-reactive NST, which is a negative CST. Did I get that right? Mm-hmm. Yes. That is not it. your patient who was 38 weeks, and she had a non-reactive NST, gestational diabetes. They decided to do a contraction stress test on her. This is her contraction stress test. She has a negative CST. So again, what I see there is I have moderate variability. I'm still not seeing those accelerations. But based on this information, it looks like the baby's able to tolerate the stress of contractions. So I'm not seeing hypoxia there for the baby. Okay. So again, looking at that strip, you don't see any qualifying accelerations. Now, remember, we don't use CST very often. The go-to, the goal, the one I would have in the toolbox is the NST. We use that all the time, CST. And the reason why is because we're gonna talk about biophysical profile, because that's really what I see used far more frequently in practice is biophysical profile. Ta-da! Biophysical profile. This is what I was talking about with in terms of a fetal APGAR. So you'll notice that this has 5 criteria. This is performed by the physician. They will do an ultrasound and look at these measurements here, and often do a non-stress test with electronic fetal monitoring. So you may have a non-stress test plus an ultrasound. And notice that there's 5 components. You either get a 2 or a 0. Do not memorize the criteria, but I would know what the components of the BPP are. So it's things like fetal breathing movements, gross body movements, the tone of the baby. So are they flexed or are they flaccid? Do I have, again, reactive fetal heart rate and a non-stress test, and then amniotic fluid volume. So with a BPP, it's important to know how many points out of what. So if it's a 10-point BPP, we generally want it just like our neonatal APGAR, we want it 8 or higher. So 8 out of 10. If they do it without the non-stress test and there's only 4 components, you can only get 8 points. So sometimes what you'll see is it will be documented maybe the BPP is 8 out of 10 or 8 out of 8 or 6 out of 8. 3, it's never an odd number. So it might be 4 of 8. One of our concerns is if it's trending downward, what is that telling us? It's an APGAR, so it tells us that the intrauterine environment is not the best place for the baby. So if I have a declining biophysical profile, the doctor will move toward delivery. Even if it's early, because we can do more for the baby in NICU and in the nursery than we can do inside the uterus. So I'll give you some examples. Let's say you've got a mom who is 30 weeks pregnant. She develops preeclampsia. They do a biophysical profile on her this week, and the biophysical profile was 8 of 8. But next week they do a biophysical profile, and now it's 2 of 8. She's not feeling the baby move. When I look, again, I've seen things in that test that tell me that's not the best place for the baby. They may try and do a labor on her, but based on that really low BPP, they usually will probably just go to a C-section. And the other thing is, if the baby's breech, that would be another reason to go to C-section. So even though she's early, we would still deliver her, because if the baby stays in that bad intrauterine, the apartment is not hospitable, the baby will not survive. This is not a routine test. We don't do this on normal, healthy pregnant women. There has to be a reason to do the test, and it's done by the physician.
How come the first one's the 8 out of 10?
Because some facilities have 5 criteria. They include the non-stress test. Some do not include the non-stress test. They only do 4. So that's kind of determined by the provider in the facility. But that's why you want to know what it's out of, because if I just say it's 8, you don't know if it's 8 of 8 or 8 of 10, or if it's 6 of 10 or 6 of 8. So you kind of want to know what you're comparing it to. So you may get that in a report where they say, maybe you're taking care of a patient in labor and delivery, they did a BPP, and they may just say the BPP was 8, or the BPP, they did a BPP during pregnancy and it was fine. Now, you're taking care of a patient in labor and delivery, she had a BPP done at 30 weeks, 32 weeks, and it was fine. That data is not essential to me when I'm taking care of her in labor and delivery at 39 weeks. It just means that there was something back there that they needed to assess the fetal well-being, but it was okay. You follow what I'm saying?
Mm-hmm.
It's kind of like a patient who has a history of atrial fib, but now they're in the hospital with something else. They don't currently have atrial fib. It's kind of a resolved issue. So I'm not going to use the history of atrial fib to say, here's the priority for my patient. Okay? I need to look at the here and now and see what's going on with my patient. Now, with non-stress test, contraction stress test, biophysical profile, ROGAM, yes or no? After the test. If my patient is Rh negative, no. There's no invasive, there's not any mixing of maternal fetal blood there, okay? So the patient doesn't need ROGAM. Whereas amniocentesis, there is the risk there, and it's invasive. So maternal fetal blood could mix. So my patient who's Rh negative would need ROGAM after the procedure. For a healthy mom who's Rh negative, she usually gets ROGAM at what gestation? 28 weeks, the beginning of third trimester, okay? If you have a patient who's Rh negative and gets an amniocentesis for genetic testing at 16 weeks, we're gonna go ahead and give her ROGAM then. ROGAM is good for about 12 weeks. So she'll get it again, a second time, right at 28, 30 weeks, okay? Let me give you another example. Maybe you have a patient who had a car wreck. And so she airbag deployed, and because of the potential for trauma, there's different blood tests that can show us again that there was some mixing there of maternal fetal blood. We call it a Klein-Hartwig key test or KB test. And if the KB test is positive, then we usually go ahead and give ROGAM to mom, regardless of gestational age, if she's Rh negative. Only Rh negative moms get ROGAM. We never give ROGAM to Rh positive moms. The letter doesn't matter. So if it's A negative, AB negative, O negative, the letter's not the issue, it's the Rh factor, okay? So with amniocentesis, what I'm doing, or what the doctor's doing, I'm assisting, is they're aspirating a very small amount of fluid from the amniotic sac. So they literally are going into the bag of water. They're taking a needle, and then they're gonna pull it out, and what should happen is it should self-seal back. That's hopefully what happens. It's a very small amount, so hopefully there's not a big change there that causes uterine irritability. If I drain a lot of fluid off really fast, the uterus the muscles are kind of reacting to that change, and they'll start to contract. We definitely don't want her contracting at 16, 18 weeks. If she started contracting at 37, 38 weeks, it wouldn't be the end of the world necessarily, okay? But the two times that we tend to use amnio are at second trimester, looking again around that 16-week window or so, and then lung maturity late in the trimester. You often have two people who are participating, so one person's directing the needle, another person has an ultrasound, and then the nurse is often assisting the patient, okay? And positioning the patient, making sure that the patient doesn't like reach down and try and grab the physician who's putting the needle in her belly. And it's uncomfortable. So what I have seen in practice recently, they used to not give any medication at all for amniocentesis. Some people would numb, like a localized anesthetic. I've actually seen some of our facilities, they go ahead and put an epidural in the patient for the amniocentesis, which I find very interesting. But again, it's helpful so that it's not, because the anxiety and the stress, and if mom moves, because if you think about it, if mom moves, then that needle could potentially hurt the baby. So if mom is stationary and doesn't move, it's going to minimize risk to the baby. So what do I do as the nurse? I want to explain the procedure, make sure she understands and she has signed the informed consent. On admission, we do the same thing. She pees in a cup, we do a urine dipstick, we get vital signs. We may or may not get some initial lab work. Again, just kind of depends on what's going on there or how long ago the labs have been drawn. In terms of, let's say she's sick, so she's scheduled for an amniocentesis, but she calls you and says, I'm just not feeling really good. I think I've got the flu. They would not go ahead and proceed with the amniocentesis. They would reschedule it, okay? So if she's sick or not feeling well, she needs to let us know, and then they may look at doing it a different date or time. We want to give her kind of that lateral tilt for the nurse. We also tend to monitor fetal heart rate as well. So we'll do heart tones before the procedure, and we'll do heart tones afterwards. So the second trimester amniocentesis, I'm not putting her on a monitor, I'm just using a handheld Doppler. And so I'm just counting, we'll look and say, yep, fetal heart rate's 150. And then after the procedure, yep, fetal heart rate's 150. If I'm doing that late third trimester amniocentesis, what we usually will want is a reactive non-stress test before and a reactive non-stress test after. Everybody with me on that? Okay. So I can't get a non-stress test in second trimester, it's too early. But because of the risk to the baby and to mom, when you do that late one, a lot of times we want it to be reactive before and then reactive after. It is considered a sterile procedure. The big risks pertain to infection at the site, but also the initiation of labor, vaginal bleeding, and ruptured membranes. So what happens if the water breaks at 19 weeks? Well, sadly, what happens generally is cord compression, and that cord is so teeny tiny, and any amount of compression there, you're kind of cutting off the lifeline to the baby, so the baby often dies. So again, very, very risky. So it's really important to watch not only for leaking from the insertion site of the needle, but any leaking or fluid from the vagina. Now, if the water breaks in late third trimester, one of the big concerns is cord compression. However, usually what we see with cord compression are variable B cells, and I would pick that up on the monitor. Okay. So the client needs to be sure and let the healthcare provider know about any unusual fetal activity, lack of fetal movement, if it's applicable, changes in vaginal discharge, contractions, abdominal pain, signs of infection, and then ROGAM is given to moms after the procedure. So the last item here, these again are not very common tests at all. They're both invasive. They have kind of a similar type of procedure. I haven't seen pubs in a while. They are still doing them, but we've not done one at clinical recently, at least at the clinicals I've been at. I've had some students who did get to see pubs at Norton downtown. Chorionic villi sampling is done in the first trimester, and that is where the healthcare provider will go in and actually take a little catheter and take a little section of the chorionic villi. And so again, we're looking at that for genetic information. Since we now have this fetal DNA test that's non-invasive, I think we're seeing less of this test being done. There's two different approaches that can be done. One can be vaginal, one can be abdominal. The other thing is that this test doesn't show us neural tube defects, and certainly there is a risk to the baby that you could miscarry or lose the baby. And then it's because of the invasive nature of it, mom does need ROGAM after the test. With PUBs or chordocentesis, this is where we can do intrauterine blood transfusion. So let's say the baby has hemolytic anemia in utero, and the baby needs to get a blood transfusion. They actually will transfuse through the umbilical cord to the baby. We don't see that very often. When my experience with it, we had a mom who had RH isoimmunization, which means that she had the antibodies. She was RH negative, but she had an RH positive baby and had not received ROGAM. So she had a positive antibody screen, and they were concerned about the baby in terms of genetic disease. There were signs that the baby had a condition called hydrops. And so the physician performed this test, again, kind of looking for that and trying to assess fetal well-being that way. But you can see here again, there certainly is a risk there to the baby. If you have to have this done, you want somebody who knows what they're doing. I've had patients who actually did a transfer, so in other words, they didn't stay here in Louisville to get this done. They had to go to other hospitals like Chicago and Atlanta, Minnesota. to a high-risk OB physician who specialized in those things. So again, very rare testing, both invasive